Well, hello there. This is Professor White, and this is the second part of antibiotics. The classes of antibiotics that we're going to be looking at in this section are ones that are generally used to treat more serious infections, including those multi-drug resistant organisms, or MDRO. So we consider something to be drug resistant if it is resistant to at least one and sometimes more classes of antimicrobials, so different antibiotics. We know what an organism is resistant to by the sensitivity part of the culture. So if you've ever wondered what it means by culture and sensitivity, it means that they've gone ahead and cultured whatever it is they want to culture, be it wounds, blood, urine, anything like that. And once they have enough bacterial growth and identify it, then they'll put the different antibiotics in the culture and see what causes the organism to die. Some of the most common that you're going to see in healthcare settings include MRSA, which is resistant to methicillin, vancomycin-resistant enterococcus, called VRE, organisms that produce extended spectrum beta-lactamases, so ESBLs, often see that in the urine. And we used to have something called CRE, which we now call CRO, and that's basically resistant to carbapenem. Staphylococcus aureus is something that's found as a normal skin contaminant. It's also found in the soil, and therefore it's common. It's seen everywhere. Not everything is methicillin resistant, however. This is becoming the norm. So there is always the concern that eventually this MRSA or MRSA will become resistant to anything we can throw at it. We're not finding the great numbers of antibiotics that we were in the first part of the 20th century, and therefore it's very likely that this could become completely resistant. It used to be that we saw MRSA only in the hospitals, but now we're seeing it in the community too, and about half of the infections out in the community are also now methicillin resistant. VRE is something that we see in the urine. It could also be in the blood and different things, but most commonly seen in the urine. And there are antibiotics that we are now using to treat VRE and MRSA, but again, we're not developing them as fast as we used to. The ones that are used for VRE currently would be linezolid, daptomycin, and tigecycline. There may be more out there. This is just a little nod to the newer ones and the ones that still work. Our ESBL infections are resistant to the beta-lactams as well as aztreonam. So they have a very narrow group of medications that can treat them, including the carbapenems and sometimes, as you see here, the quinolones. But with the increased use of the carbapenems, we noticed that there was increased resistance to carbapenems. So this is the problem, right? That we have a lot of antibiotics being used, and then the bacteria becomes resistant, and it renders an entire class useless. This is why it's so important that we have good antibiotic stewardship. This is why we should only be using certain antibiotics for certain infections and to use them to the completion of therapy. We all have a hand in creating a safe environment for our patients and reducing the chance of drug-resistant organisms. The aminoglycosides are among the oldest of the antibiotics or antimicrobials, first discovered in the 1940s. So it was actually isolated from actinomycetes. Streptomycin, which came from the Streptomyces, was the first aminoglycoside that was introduced into clinical practice, and it was used for the treatment of tuberculosis. In fact, Selman Wakeman won the Nobel Prize in 1952 for the discovery of streptomycin, and he was the first to coin the phrase antibiotic. And Albert Schatz was also recognized eventually as being a co-discoverer of the aminoglycosides. So aminoglycosides, because they're among the oldest, they're some of the most potent antibiotics that we have out there, and they were used for almost 80 years. There were approximately 15 different members of this class, but the use of the aminoglycosides declined because there was the development of the other classes, including the cephalosporins and things like that. But now, as we have a resurgence of antibiotic resistance, we're seeing these medications come back into play. In fact, as we go on to the next screen, which is here, you can see that plasmomycin is the first new aminoglycoside. It was to be approved by the FDA in nearly 40 years. So this may be a new chance to rejuvenate this class. Aminoglycosides are rapidly bactericidal, meaning they kill and they kill quickly. They're active against gram-negative and gram-positive, including those multi-drug resistant organisms. Some of the medications are listed here. So streptomycin, amikacin, gentamicin, tobramycin, and then neomycin, which sits in a little bit different of itself, and we'll discuss with that. But something to take away from here too is that aminoglycosides are often used in combination with other antibiotics, such as our beta-lactams or vancomycin, which, despite being called vancomycin, is not an aminoglycoside, though it causes a lot of the same problems. But again, the combined effect of these two antibiotics is greater than either one. So the aminoglycosides, you can see streptomycin being used to treat tuberculosis along with amikacin. Gentamicin is used to treat eye infections, ear infections. It can also be given intravenously. Tobramycin is generally reserved for eye infections and then also Pseudomonas infections. And then neomycin is one of the very few that is absorbed in the GI tract, and that treats encephalopathy and also sterilizes the GI tract before a lot of GI surgeries. So here you have, even though we have a gram-positive effect, they're generally used for a lot of gram-negative activity because of the types of bacteria that are out there. We talked about the synergistic effect of giving it with the beta-lactams or vancomycin. And then, of course, gram-positive resistant organisms. Of note, streptomycin, with its action in the lungs and against those myobacterial infections, it's also been used to treat cases of the bubonic plague and the pneumonic plague. All right, so let's go on about some of the administration. Many of these medications are given IV, and that's because there's really not a good amount of oral absorption. And the exception to that rule really is neomycin, which can be given through the GI tract. And we spoke about that in a previous slide. We can use the inhalation form of treatment for lung infections, and this would include giving tobramycin for Pseudomonas in our cystic fibrosis patients. And parenterally, we could use it for lower respiratory tract infections, osteomyelitis, UTIs. There's a lot of different reasons we might use one over the other. But again, in clinical use, streptomycin, kanamycin, a lot of those, they're used infrequently because of the threat of clinical resistance or antibiotic resistance. Streptomycin and gentamicin, they're really considered first-line treatment for what we talked about already, a little bit like the bubonic plague and stuff. But the big problem that we have with these aminoglycosides, and I want you to think of them as mean medications, they cause a lot of side effects, a lot of adverse effects. So nephrotoxicity and ototoxicity, these are known safety concerns that are associated with the use of these aminoglycosides. The aminoglycosides are readily taken up, they're readily retained by the kidney and also in the cochlear cells, and that's why they are cytotoxic. So we need to be aware of the signs and symptoms of this in our patients. So the signs of nephrotoxicity would be noticed by looking at the BUN, or blood urea nitrogen, and the creatinine levels. As those rise, we can assume that the kidneys are being damaged. Ototoxicity may present in your patients as tinnitus, dizziness, hearing loss, sort of feeling a fullness in the ear. And again, that can be a very potential serious issue, because once the hearing is gone, it will not come back. Some of the other concerns that we may have with the use of this class of medications would be headaches, paresthesias, worsening infection, and of course, superinfection. The big takeaway here is to use the least amount of the antibiotic that works. So we want something that's therapeutic. We want to use it for the least amount of time possible, but at the same time, make sure that we give enough to kill the organism, because a weakened organism can develop resistance. And the other thing is the monitoring the drug levels. Because of these drugs being aminoglycosides, it means they're the old and mean meds. They can cause some serious problems, and they have a sort of narrow therapeutic index. So we look at the serum levels, we measure them to prevent toxicity. So the peak is the highest drug level for a once daily regimen, and the trough is the lowest level to ensure that the kidneys are not damaged and avoid toxicity. So you can see the different levels, and this is just a little picture I had found about the aminoglycosides. So anytime we have abnormal lab values, you want to make sure you're letting the provider know, and if you have any signs of ototoxicity or nephrotoxicity. The other thing that I'd like to mention is concurrent use of medications that affect the ototoxicity, so that affect the hearing and affect the kidneys. Concurrent use of them can actually cause more synergistic relationship in that, and that the patient would be more likely to develop those complications. So loop diuretics, which are commonly used, can cause hearing loss, and they can cause kidney issues. And so if they're used concurrently with things like gentamicin or any of these aminoglycosides, but again, I think gentamicin is going to be the most common one that you come across, to be aware that they could have an increased risk of problems related to the ears and the kidneys. All right, so next we're going to talk about the fluoroquinolones. I'm actually going to slide up one of these slides in front of it, but so we can sort of look at them. So basically the fluoroquinolones, they're used to treat eye infections, they treat chest infections, a lot of GI issues, some UTIs, some STIs. They're also called the fluoroquinolones and also the quinolones, okay? So these are the medications that end in fluoxetine. So most common ones to be used would be like ciprofloxacin. This medication, these fluoroquinolones, can also treat anthrax, which is pretty interesting. So let's go down here to the mechanism of action. The quinolones are bactericidal. They work by inhibiting the DNA synthesis, and that makes them unalived. They do not affect human DNA, so they're safe for human use. And they have a really pretty broad spectrum activity. They can treat urinary tract infections, respiratory tract infections, and like I said, drug of choice for anthrax. But there are quite a few interactions. Some of the interactions are here. The most important ones to take note of are that these fluoroquinolones cannot be taken with anything containing any of the cations. So this would be calcium, magnesium, iron, zinc. And in fact, you must administer these at least an hour before or several hours after taking this antibiotic. There's an interaction with dairy because of the calcium. There's an increased risk of developing C. diff, so make sure your patient reports any diarrhea. And you want to take these meds with plenty of water because of the crystalluria. So let's look at some of the adverse effects. The fluoroquinolones as a class cause a lot of GI distress, so nausea, vomiting, and diarrhea. Dizziness, headache, confusion, potential phototoxicity. There is a black box warning that is required for all quinolones because there's an increased risk of tendinitis and tendon rupture with the use of these antibiotics. This adverse effect is going to be more common in our older patients, any patient that has renal failure, and anybody that would be taking prednisone or another glucocorticoid therapy. So I have here a picture for you of what a tendon rupture might look like. And as a nurse, you would want to be constantly assessing your patient for any changes in their gait, new complaints of pain in the legs, and assessing their ankle area to look at the tendons. So this new class of drugs is called the pleuromucilins. These really aren't that new. They've been around since the 1950s. And in fact, they had been used in veterinary medicine. They worked really well against a lot of mycoplasma species and some of the other species, especially in pigs and poultry and even rabbits. So, and resistance, when it's been used for veterinary use, has been really uncommon. But despite having some evidence that these would be useful in humans, there really wasn't any marketing authorization up until this new century. So there's a lot more interest in this class now because of the potential for drug resistance. And as a result, there's been the development of these two medications that are used for humans. So that cream that you see down below, that Altabax or Retapumulin, is used to treat impetigo and basically guard against staph and strep infections. And the new one, this Lefumulin, is the first one that's been made for IV and oral administration. It's in clinical development, and it's being used for community-acquired bacterial pneumonia, acute bacterial skin infections, skin structure infections. But basically, these are getting a little new look at them because we need new antibiotics to be made. So you may see those out there more and more as we get, I guess, a little more fancy-free with making our antibiotics here. All right, so the next class that we're going to look at, and there's only one medication really, potentially, well, there's two in here, but this is a lincosamide. The exemplar drug is going to be clindamycin. So clindamycin is bacteriostatic, but it can be bactericidal in certain situations. It inhibits bacterial protein synthesis. And the one thing that I've always remembered about clindamycin is that the D stands for diarrhea and C. diff. So most common adverse effect of this medication is going to be diarrhea. And there is a severe risk of a superinfection with C. difficile. Rarely hepatotoxicity and some blood dyscrasia. So because of the risk of C. diff infection, there's really limited use because of this. If there are signs of C. diff associated colitis, so if we have pseudomembranous colitis, the medication should be discontinued. Additionally, this is to be given slowly through IV, because if it is administered too fast, it can result in heart changes, low blood pressure, and actually cardiac arrest. So let's take a look at the next slide. And also you can see here potential interaction with vecuronium. So vecuronium is a neuromuscular blocking agent, and it will increase the effects of that. So daptomycin, though it looks with the same sort of spelling as of clindamycin, is more of a lipopeptide. We don't really know how it works, but we do know that it disrupts the cell membrane, and it is used to treat soft tissue infections, and we're using it to treat MRSA and VRE. So it's got some definite use for us. This is one of those medications that a provider just can't order. Infectious disease has to sign off on this. In fact, that's the case with a lot of these big gun antibiotics. Now, this one is one that you're not going to see that often, so I think we won't spend a lot of time on it. The other name for this is polymyxin B, but colistin. So basically, this is used for gram-negative cocci. Lots of adverse effects with this, and the most serious among them being acute respiratory failure if it's used by inhalation. It can be used for bacterial infections otherwise in other parts of the body, but it's not going to be a first line for anything, and you may see it otherwise. I wanted to correct something. I did misspeak that polymyxin B is not this one. This is polymyxin E. And if given the opportunity, most people would prefer, and most clinicians would prefer to treat with polymyxin B because, you know, it may not require loading dose and all sorts of things. There's not as many cons. Polymyxin E does require a loading dose and higher rates of nephrotoxicity and stuff. So, but it is in the polymyxin class. Dalbavancin belongs to the same class of vanco, which would be the glycopeptides. So we'll talk about the glycopeptides a little bit more. Understand that this drug belongs in this class. I guess I should move the slide around, and we can. But you can look at this to see that it's used for the treatment of skin infections for gram-positive, which means it's really effective against MRSA. A very long half-life, dosed once a week. Pretty well tolerated. But again, this is one that the infectious disease doctors are going to have their hands on. This will not just be given out. Linezolid belongs to a class called oxazolidinones. This medication started to be really discovered and looked at in the 1970s, but it wasn't until the 90s that it really took some hold on us. Basically, it's been approved by the FDA for treatment of hospital-acquired pneumonia from staph, including MRSA. It's used for drug-resistant strains of strep. It's used for VRE, complicated skin infections, and also strep pneumoniae, including pneumococcal meningitis. It's actually being used right now to, at least it's being investigated for those with multi-drug resistant tuberculosis. It does, however, have a lot of interactions and some adverse effects. So it can cause life-threatening serotonin toxicity if it's combined with the serotonin reuptake inhibitors, so the SSRIs. And so you need to be able to monitor the patients for that, but it's not contraindicated, okay? But it can cause it and needs to be monitored for it. There's reactions if it's taken with tyramine-containing food, and it can cause hypotension. Metronidazole is an antibiotic that's also it's a pretty cool one, and we'll talk about this under one of our other lectures, but it is an antibiotic. It targets those anaerobic organisms, so it's going to be used a lot in the gut. And also for gynecological infections, it's effective at treating protozoa. Lots of different drug interactions. But one of the most important things for us is the fact that it has an antabuse-like reaction with the use of alcohol. In fact, we're finding that it can cause this reaction if alcohol is consumed up to 30 days after this antibiotic. So that's why I put the notice here for no alcohol beyond this point, because your patient can suffer nausea and severe vomiting. And just as a little aside, the IV form we have to protect from light. All right, so let's move on down to nitrofurantoin, also called macrodantin. Macrobid is another form of this. It's just in how it is basically broken into whether it's given twice a day or more often. So macrodantin actually belongs to a class of medications called urinary antiseptics. So this is why it's generally used for the treatment of lower UTIs. It's bacteriostatic and may become bactericidal. We don't know exactly how it 100% works, but it damages the bacterial DNA. Some of the major side effects of this medication include nausea, vomiting, and diarrhea, hypersensitivity reactions, some changes and problems with our white cells and platelets. So you'd want to make sure that you're monitoring the patient's lab values for any extended therapy. It is contraindicated in patients with renal impairment because what it does is it concentrates into the urine, and if the kidneys are impaired, then the patient will become toxic from the medication because they won't be able to concentrate it into the urine. You can give this one with food to help with the GI distress. Remember monitoring the complete blood count, and it may turn the urine darker in color. And it's rare to happen, but if it does happen, it can be a fatal issue with hepatotoxicity. So check and make sure your patient doesn't have liver disease. So this one of our newer antibiotics, this is called Sinercid, which is quinupristin and dalfopristin. It's a macrolide lincosamide streptogramin antibiotic. So basically it's a combination of two products that are derived from pranistomycin. So it's a 30-to-70 ratio. It was approved by the FDA in 1998, and it took a long time for it to be available for manufacture. It took almost to 2000, and that's because it takes almost 9 months to create the manufacture of this. For this class of medications, arthralgias and myalgias, they have been reported in patients receiving this, and sometimes it's severe enough that they have to discontinue therapy. So something that may come up, that you may see it a little bit more often here and there as we need new antibiotics. This is one that also inhibits cytochrome P450. Telavancin is also a glycopeptide, so same class that vancomycin is in. There are newer drugs that we'll use, so that dalvabancin. The reason we don't use this one as much is because of the issue of QT prolongation and otherwise, but just to know that this belongs in that same class. Let's go on to vanco. All right, vancomycin is the antibiotic of choice for the treatment of MRSA. It's commonly used in the hospital, so you will see this in our patients where we're not 100% sure what's going on. We'll often give them vancomycin and Zosyn, so the penicillin tazobactam. Remember that vancomycin has a lot of interactions in the same line, so you want to be careful with that. It can also increase the neuromuscular blocking effects. It can be given orally to treat C. diff. We do require monitoring for the blood levels, and we'll talk about that on the next slide. There's something called Red Man syndrome, which we'll be able to look at as well. I have a picture of it. And the best way to avoid Red Man syndrome is to infuse the medication over at least an hour, so you will never see vancomycin given any sooner than that. We want the patient to have adequate hydration, at least 2 liters of fluid in a day if it's not contraindicated, because that can help prevent the nephrotoxicity. And rapid infusions can cause low blood pressure, so you want to make sure that we don't give them too rapidly. Let's look at the peak and trough here. So peak and trough are important for vanco. So optimal levels of vanco are considered to be between 10 and 20 micrograms per milliliter. So we don't generally do peak levels anymore with vanco, but the trough is very important. So we draw the levels for the trough just before the administration of the next dose and look to make sure that it is not toxic. Now, when we're treating antibiotic-resistant organisms, many doctors and clinicians, they want the trough to be between 15 and 20, but understand that therapeutic is 10 to 20. Here is a picture of red man syndrome, and that's what can happen. The other things about vancomycin is that it can be definitely nephrotoxic. That's one of the main things we look at. And if somebody has renal impairment already, it has to be renally dosed because it is picked up and excreted by the kidneys. All right, so as we end here in our group of antibiotics, a couple of little cartoons for you and a reminder that antibiotics oftentimes can wipe out good flora and cause lots of diarrhea and some other issues, yeast infections in females. And so a good probiotic goes a long way. And then remember, no matter how popular they get, antibiotics will never go viral. They are used for bacteria only. Thanks for sticking with me through this lecture, and we'll chat again soon.